webinar on preventing and managing COVID-19 in the workplace. Thanks so much for joining us on this day before Thanksgiving. You're our intrepid followers, and if you're new, we welcome you. We really enjoy these weekly get-togethers and appreciate your ongoing participation. This is Karen O'Hara. I'm the Director of Marketing and Communications at WorkCare and the moderator for today's session. As you know, if you attend every week, we do record the session and take questions using the Q&A function that we answer at the conclusion of Dr. Harris's presentation. We usually take about half an hour for the presentation and 10 minutes for questions. All the questions and answers are posted on our website, and we also post the recording on our YouTube channel, and those links will be in the chat, so you can refer to that. I also wanted to direct you to a blog that we just posted this morning on Thanksgiving safety and some ideas you might be able to share with your employees to make sure they have a healthy and safe holiday and can come back to work free of infection. To expedite the session, I know Dr. Harris always has a lot to cover. I'd just like to quickly introduce him. Anthony Harris, MD, MBA, MPH, is our board-certified occupational medicine physician, Chief Innovation Officer, and Associate Medical Director for Onsite Clinical Operations. He's also our lead clinician for WorkCare's COVID-19 response. And now I'll turn it over to him. Thank you.
Excellent. Thank you, Karen, and thanks to everyone for joining us on this day before Turkey Day. I would love to promise you that we're going to keep it more brief than usual, but as usual, we have a lot to pack in today. So we're going to get to it here. If you're joining us for the first time, welcome. The format is pretty straightforward: clinical update followed by some pathology. And then we're going to talk about how we're faring in the global sphere of COVID-19 responses in the U.S. and abroad. Then we'll talk about prevention, and then finally strategies that we recommend in terms of keeping your workforce safe. So let's dive into it. As we approach the holidays, we want to update on some clinical presentations. And we want to be very, straightforward, that we want to help you understand what to communicate to your employees about travel and travel risks, okay? And at the end of the day, that's what it's all about for the holidays, education, and hopefully people being attuned to the safety protocols that are necessary to protect themselves, their family, and their coworkers. So we want to quickly touch on some risk factor levels. This is risk factors that are published by CDC, starting with low risk for interactions with individuals, okay? And if you're interacting with household members, you're considered low risk, both indoors and outdoors. The people you live with, frankly, is the best way to keep safe during the holidays, restricting it to only the people you live with. More risk is imparted if you're starting to interact in a local area, meeting people outdoors. Obviously, always wearing a mask is a plus in terms of prevention of droplets and contamination, fomites, and things of that nature. And then social distancing, 6 feet away, and you're not sharing food, drinks, and things of that nature. Again, lower risk and more risk are pretty straightforward in terms of what I believe most people understand about how to stay safe. Now, we know people are going to engage in more risky activities, right? And that's the even more risk in terms of now your social circle includes your neighbors and other community members. You're meeting hopefully in well-ventilated outdoor spaces, well-ventilated indoor spaces, and that's going to help keep, to a degree, a better profile of safety than compared to if it's an enclosed space with poor ventilation. In that more risk category is in the event people are not wearing masks in cases, and they're not doing the social distancing with only people who they live with, okay? And if you're sharing food, obviously during Turkey Day and during the holidays, there is a strong propensity for food sharing, right? But if you can't hold off from doing it, try please to do it with the least people, the least number of people as possible. And then finally, in that highest risk category, right? This is interacting with larger crowds. This is not practicing social distancing. And if there's a high community spread of COVID-19 and you're out and about, obviously you're at greatest risk there. And if people aren't wearing their masks, you're in poorly ventilated spaces. Again, you're putting yourselves and your workers are putting themselves at risk. And these are the things that we want to communicate over and over and over in the holiday season, particularly, but obviously when we get to the other side of the holidays, New Year's, we want to keep these in mind. If we're talking about these different levels and breaking them out, please communicate them in succinct ways. One pagers, two pagers that you can distribute to your workforce is going to be key. If we jump into kind of reviving or updating, if you would, our messaging on survival in critical care facilities in the hospital, we touched on this time to time. We want to update you here in this clinical update presentation on are we indeed continuing to learn and have we consistently seen evidence of learning better ways to treat individuals in the ICU. And in this particular study that was recently published here in October, late October, this data comes from comparison of 21,000 individuals, roughly 21,082 to be precise. And we were looking at the improvement in survival. If you were admitted to the hospital and you were in a step down unit, which is a step below the ICU, which is still pretty high dependency units, and if you were in the ICU unit. And so what we found in this study that looked at when the lowest survival existed, that was during late March of this year, okay? It was 71.6% survival in the high dependency unit, step down unit, and 58% survival in the ICU, okay? So roughly only half the people at that point in time were surviving once admitted to the ICU. By June, those numbers had improved considerably in both categories. So those unit had a 92.7 survival, and those in the ICU had an 80.4% survival. Okay, so again, more evidence recently coming out demonstrating that we are getting better at critical care for those infected with COVID-19. So this is positive news as we approach the holidays, and we know that because of the holidays, just like we saw back with July 4th and Memorial Day, etc., we know that there's likely going to be an influx of cases even beyond what we're seeing in terms of spikes now. We'll talk more about that here shortly. Let's jump into the pathology update here. For the pathology update today, it's something that is a very touching kind of presentation for me personally, having small kids at home, and we want to talk about the effects that we're seeing from a pathology standpoint with children, right? Because we all can understand the predilection to think that children are going to survive COVID for the most part. And yes, statistically that's true, but it's still impacting children in a tremendous way. In this case, a young lady who passed this week from COVID-19 made news earlier this year, made news several years ago when she was 11, 2017. She was apprehended, handcuffed by police officers as they were searching for her aunt involved in a criminal case, right? And it made the news because she was on film begging not to be handcuffed. And she, again, recently passed this week due to COVID-19 and complications thereof. And so we want to, with this type of news of children, again, being affected by COVID-19, try to go deeper into understanding how they're being affected, why children are dying of COVID-19. And one of those factors is something called multi-system inflammatory syndrome, okay, MISC, because it's in children, is something that's been associated with COVID-19 infections in kids, all right? And this type of infection can infect the heart, the lungs, the kidney, brain, skin, eyes, and the GI system, gastrointestinal system. For the young lady who we presented, I want to mention her name, Honesty Hodges, right? She passed from brain complications, all right? And so we don't know exactly what causes this phenomena in children. It's associated with inflammatory processes, but as we learn more and more about how it presents, we know that kids present differently with signs and symptoms of multi-system inflammatory syndrome. Could be fever, abdominal pain, neck pain, etc. Right? So we want to communicate this, not to frighten any of our employees, not to really kind of send fear and terror, right? That your kids are substantially at risk of this particular illness. But we do want to communicate it in critical times to help people understand this is still a very serious illness potentially, and we want to take precautions because we want to protect young folk who don't have any pre-existing conditions, as in this case with honesty, of outcomes such as this, right? Death. And so when we talk about the pathology of what potentially can cause multi-system inflammatory syndrome, we look at profiles of antibodies, again, looking for reason of this profound inflammatory process that leads to these multi-system organ failures, all right? And this particular assay and study looked at neutralizing activity antibodies targeted at particularly the spike protein. And what we found is that in adults, what this study has found in adults, we see a increased profile of antibodies to the SARS-CoV-2 virus as compared to what we see in the pediatric children that were studied in this case. All right. So put another way, if we want to look at then those antibodies like IgG, IgM, IgA, and anti-IgG in summary, looking at all of them, we can see that in the anti-S, which is the anti-spike protein, IgG, we see that difference, right? If we look to those highlighted means here, these averages of the antibodies that were counted, the adults who were not exposed or excuse me, the adults who in this case did not have acute respiratory syndrome. These are people who were in the ICU, most likely on ventilated support, versus those who had disease that weren't in a critical care setting. These individuals the individuals in the ICU had higher counts of antibodies, all right? So let's simplify that again. The sicker you are as an adult, the more likely you are to have higher levels of antibodies in your system. When we look to children, however, we don't see that same linkage. Those kids who developed MISC, the multi-system inflammatory syndrome, did not have higher counts of antibodies to the SARS-CoV-2 spike protein, particularly IgG, compared to those who did not have MISC. All right, and we see that pattern play out not just with IgG, we see it play out with IgM, we see it play out with IgA as well. And so what we are understanding because of this data is that the children who are falling ill with this syndrome at risk of death is not a function of the antibody response to SARS-CoV-2. And that may have implications in terms of vaccinations and the vaccine development as we are approaching the precipice of the vaccines being available to both adults and pediatric populations. Okay, so we'll continue to look at this in terms of particularly of its impact pertaining to children and vaccinations. But this is something to make note of in terms of understanding how these phenomena are playing out in our pediatric population. So let's move into our epidemiology. Let's start to examine how we're doing in the US. And obviously, this has been a rough week, right, for us in the US. If we look at where we were 2 weeks ago with total cases, we were at 10 million and 34.6 over our 7-day rolling average per 100,000. We increased that last week to 11.1 million and to 47.5 per 100,000. And now we're well over 12 million, almost 12.5 million at 52.3 per 100,000. So clearly we are accelerating our pace of infection in the US for SARS-CoV-2. And that is following, that also follows along with what we're seeing in terms of deaths, right? 10, at the 10 million mark, we had zero point 0.3 per 100,000 in terms of 7-day rolling average with deaths. That went up last week to zero point 0.4 per 100,000 when we hit that 11.1 million. And this week we're at 0.5. All right. And so we're going to dig into this a little bit more deeply as we talk about prevention and what to anticipate as we move forward. But it's clear we're continuing to have a profound effect across the board in terms of impact from COVID-19 deaths as well as cases. If we look at total cases compared to our neighbors here, obviously total cases, US is still leading the way. That's where we were 2 weeks ago, where we were last week. France and India seeing declines in their total cases, and the US continuing to climb. Again, the confidence of accurately reporting the numbers, particularly in India, is low, right, because of access to testing. However, we still want to continue to watch these trends, as someone pointed out in the Q&A last week. If we look at per million in terms of population, we see France has started to have a decline. Again, they instituted the curfews 2 weeks ago. We see that decline continue last week. And then we see the United States, in this case, continuing to go up per million. And we want to compare it to the United Kingdom, which also instituted restrictions and curfews, seeing a decline. If we look at deaths, the trailing, 30-day trailing lagging indicator, we see deaths continuing to climb in the US from 2 weeks ago to last week, as well as this week, right? We're continuing to see escalation of deaths, ICUs becoming more utilized in terms of our total utilization. Next week, we'll look at those numbers again that we presented several weeks ago of capacity of ICUs nationwide and our current state of utilization. That will give us a good update on how we're faring in terms of prevention overall, as well as poor outcomes and severity of illness across the board. If we look at deaths per million, we see France is still leading us 2 weeks ago, with the UK and then US following that. And then the United States staying in that third place position last week. But we're making still, unfortunately, increases here in the US per million in terms of deaths, while we see in France and the UK plateauing and France declining with their measures in place. If we look at then total tests, we saw India and the United States going back and forth with the number of total tests for COVID-19. The U.S. taking a decline here last week, and we see that decline persisting, although the total number of cases relatively have trended upward. We're still not seeing a clear sharp increase in access to testing. We know that there's still hope because we see new technologies coming on board in terms of access with home testing, et cetera. So we should see this trend hopefully sharply increase in the weeks to come as we watch this metric. Per 100,000 in terms of daily tests, France is not doing too bad, right? In terms of fully articulating the burden of illness in France, they're probably doing a good job based upon this particular metric, followed by the UK and then the United States. That was where we were 2 weeks ago, where we were last week, and finally where we are this week in terms of the United States being able to make some improvements in terms of our per capita testing. If we look at then our one of our important metrics about understanding the burden of illness and accurately articulating the burden of illness, we look at then the percentage of positives, right? At this point, we were 2 weeks back. We saw this metric increasing consistently. We saw it continuing to increase last week compared to the United Kingdom overtook them as well. And we then look to this week and see a dramatic increase in our percent positive tests, right? And so, again, realizing that as we are at this point, 12.7% positive rate for the tests that we're conducting across the board in the U.S. as of today, realize that that is still likely drastically underestimating the actual burden of illness in the U.S., right? And so as we talk about prevention, we'll kind of jump into that, continuing with understanding these metrics and going a little deeper into some of these metrics. You all have seen this play out this week, right? As of yesterday, 2,100 deaths in the U.S. from COVID, deadliest day since early in the summer, right? And so we're at the point where we're going to start surpassing obviously the deaths that we saw back in the summer, and we'll see how that plays out relative to what was predicted or what other epidemics can tell us from a standpoint of impact from SARS-CoV-2 and how it's going to play out. So let's talk about comparing now SARS-CoV-2 to the Spanish flu, right? 1918 influenza pandemic. We're going to look at the United Kingdom because of the level of data that they had available in 1918 in terms of understanding the deaths, estimated deaths from the influenza outbreak then. And this particular study examines the comparison in such a way that we can see how COVID-19 stacks up in the UK, also in in Wales, to the influenza of 1918. Okay, in this first chart here, we'll zoom in into that, and we'll look at in the red. You can see the weekly level of infections, right, per 1,000 individuals back in 1918 from the Spanish flu. All right, and we want to look at then the triangular or diamond-shaped blue tracing there, and that's estimating in the UK the SARS-CoV-2 COVID-19 impact. Again, weekly COVID-19 infections per 1,000, and you can see the tracings are pretty aligned in terms of this particular metric. And this is particularly looking at an estimate based upon cases. Okay, so this study examined if we take the cases that have been reported back in 1918, also back in February of this year, up till now for SARS-CoV-2, COVID-19, and we try to match the data in terms of timeline, this is what it looks like. And this, again, is weekly COVID infections. If we jump to another way of looking at this data, let's look at the R number. We talked about that R naught number, the reproductive number for a particular illness, and how it has ranged from 2 to 5 in much of the US in terms of number of people infected by a person who has COVID-19 on average. This particular metric and chart looks at then comparing SARS-CoV-2, COVID-19, to the Spanish flu and the R naught. And again, we can see how these tracings align decently in terms of the R naught over time. Okay, so at the bottom of this chart, you see weeks since these the start dates of these pandemics. All right, in August 25th, 1918, 10 weeks, 20 weeks, 30 weeks, and 40 weeks out, and then February 6th here in the again, this is looking at the UK, and 10, 20, 30, and 40 weeks out. All right, and so when we examine this data, looking at the other means of understanding this perspective, we can get a sometimes more accurate picture, as we've talked about before in this presentation, looking at not just the reported cases, but looking at the deaths, right? So extrapolating the number of cases that existed based upon the death rate of a particular illness, in this case, COVID-19 and the Spanish flu from 1918. So if we look at that data, this is how it pans out, right? So now we're looking at estimates based upon deaths, and that being perhaps more accurate than reported cases, realizing the reported cases are underreported for what the number of cases actually existed. But if we look at the death rate and extrapolate back to the number of cases, total number of deaths, and then extrapolate back to the number of cases using the death rate estimate, then we can get a better, more accurate picture. And that's what happened in this case with this particular study. 44 million back in 1918 compared with 59 million in Wales in 2020, right? And the assumption of the infectious rate, right? In this case, zero point 0.5 for COVID-19 and 2% for the flu back in 1918. That's what was used to extrapolate this data in terms of estimated number of cases and this pattern that we're seeing align. All right. And if we use this data, again, the zero point 0.5 for COVID-19, it's reasonable based upon serologic studies. So last week we talked and updated about the serology studies that were sampled broadly in the US and trying to estimate the true number of people that have been exposed to COVID-19. Again, similarly, that's what happened in this that's what was done in this particular study to estimate how the Spanish flu and COVID-19 is matching up. Now it's time to get a little sober about expectation of what we will likely see play out from COVID-19 as it exists right now, right? So if we look at this tracing from the flu, Spanish flu, right, in 1918, 20 weeks out, and we match that up with the estimate, in this case, weekly COVID infections per thousand, the triangular blue, or excuse me, the diamond shaped blue here, 20 weeks out puts us in the summertime, right? And if we fast forward to 36 weeks out, that puts us as to right now where we exist with regard to our impact from COVID. The Spanish flu saw a decline at that point, right? 36 weeks out, they were declining in the number of cases per 100,000. We are not, certainly. We just talked about that and looked at those metrics. So we're going to likely see a greater impact from COVID-19, perhaps than the Spanish flu. Obviously, we have other interventions to help with death rates, but anticipate that things are going to get dramatically worse because we're not seeing a matching late into our pandemic as we have seen with Spanish flu. And again, that's pretty sobering if we take that perspective from this particular body of data. So what do we do about it? Do we run around with our hair on fire thinking that, it's kind of hopeless and things are going to, continue to spiral out of control in terms of number of infections? Obviously, we're looking to a vaccine to help us cull the numbers that we're seeing in terms of infections. But we got to come up with a strategy that deals with this increasing incidence so that our workforce can continue to be productive, hopefully safe first and foremost, and stay productive after encountering COVID-19, both exposures as well as recovery. So what does that look like? It looks like much of what you already understood to be the new normal, right, for us until next year, when the vaccine is widely distributed, right? The daily screening, remaining at home, COVID testing, hopefully local testing, and the return to work protocol, right? And then we talked about the new norm also including some type of on-site testing. So we'll pause there. You got to have testing on site to some degree or near site to some degree to help weather this storm, right? Because it's going to continue to get worse. We're going to see increasing absenteeism. And without a testing strategy that's reliable in proximity in terms of turnaround time being quick, increasing absenteeism will become a problem, if not already, if the local incidence is substantial for your population, your workforce population. So we want to make sure that we focus in on this particular strategy. We talked about pooling being the most likely best ROI for a strategy implemented for an on-site or near-site campaign in terms of surveillance as well as return to work testing. And then we talked about strategies that stratify risk to try to better manage resource allocation, right, based upon case rates locally, right? And so all those things continue to be in play. What we want to introduce today is a strategy for post-exposure that shortens the level of or the amount of time that quarantine is necessary. All right, we first presented this information last week to some of our clients. We want to present it here more broadly to this audience so that we are thinking about how do we keep absenteeism at bay, but also at the same time keeping our work population as safe as possible. And so what could that look like? So for those individuals who are medium to high risk in terms of transmission, we want to create an algorithm that if they are exposed and they are asymptomatic, right, They begin their 14-day quarantine as usual. But on day 5 to day 7, depending on your level of conservative approach that you want to take as a company, you institute diagnostic testing. And if that diagnostic test for COVID-19 comes back positive, obviously that individual will complete their 14-day quarantine, which does incorporate the isolation period necessary, which is 10 days post positive result, or post, in this case, no symptoms, so post positive result, such that they're no longer infectious. If they are negative, however, getting that individual back 7 days post exposure becomes a possibility, because we now have a diagnostic test, in this case PCR, not antigen is what we want to suggest, a nucleic acid assay, negative for COVID-19, day 5 to day 7, can reintroduce the individual back into the workforce safely with a low likelihood of having COVID-19. Granted, they're still going to wear their precautions, their masks, do all the precautions in the workplace that we need them to do to stay safe. But again, this allows us to introduce a methodology for shortening absenteeism. We call it potential absenteeism reduction. As we assess this particular method, we like golf, so we called it a par 7 in this case, so we can quickly articulate the benefit of this type of algorithmic approach from a clinical clearance standpoint. And then we want to look at, what do you do for an individual that has no exposure, but they're symptomatic, right? Again, medium and high risk individual with symptoms that present will begin a 10-day isolation period. And that isolation period for 10 days can be modified with diagnostic testing on day 1, all right? And day 1, if positive, obviously they complete their 10-day isolation to the point where they're no longer infectious, right? But if they're negative and they are asymptomatic for 24 hours, symptom-free, then reintroducing them to the workplace becomes a possibility. Why? Because during this cold and flu season, right, if you recover asymptomatic from the cold or from a flu, then and you have a negative diagnostic test, then we can get you back. And that becomes very reasonable in terms of low risk for COVID and keeping individuals safe and not prolonging their absenteeism from work. Par value, 7 days, all right, in terms of benefit of this particular algorithm. Now, finally, let's look at a methodology that incorporates serologic testing. I know what you're saying in the back of your mind when you saw that word serologic testing, that you know, no one's doing it, right? Serologic testing has gone by the wayside because of low sensitivity and specificity. However, we know that the sensitivity and specificity of serologic tests have dramatically improved. And FDA, EUA approval of certain tests are now in the high 90s in terms of sensitivity and specificity. So with that being said, we know that serologic testing now can play a role in clinical algorithmic clearance for individuals in certain circumstances. So what could that look like? We have a individual who's asymptomatic after an exposure. They begin, you know, at that point, if they have, at that beginning point, if they have a positive history of COVID-19, right, they now are in a methodology by which we get them tested with antibodies. And if that antibody test that now has higher accuracy is positive, then we accelerate their return to work. No longer do they have to have a long 14-day quarantine period if they're asymptomatic, obviously in this case. 24 to 48 hours post-exposure, we can accelerate their return to work. If the test is negative, again, we're talking about the antibody test, serologic testing, then they continue their routine post-exposure protocol, right, for COVID-19. And so again, this methodology allows us to capture a substantial benefit with a par value of 12 so that we're not seeing the impact of absenteeism by COVID-19 during this period of increasing incidence that we otherwise possibly would see if we don't update our methodology and our clinical algorithms to both keep people safe, but keep them at work and productive as best as we can. Now, are we alone in this in terms of endeavoring to provide advances to this clinical perspective? No, right? CDC has recently, just yesterday, come out and said, we're going to make updates as well. Specifically, officials have come out, not on record yet, to say what the numbers will be, but officials at CDC says it's likely to be 7 to 10 days for people who test negative after a virus to shorten their quarantine period. So we know it's coming. We've consistently led expectations and what CDC has suggested here at WorkCare. And that's what we're continuing to do in terms of understanding the science, understanding the clinical impact, and providing strategies that allow you to keep your workforce safe, but also productive. And as we approach the holidays in this high impact time of flu and cold, we want to make sure we have the best practices in place to do so. So with that, I will allow all 95 of you who have joined us this day before the holidays, thank you, to go into the question period. So let's do it. Thank you.
Thanks, Dr. Harris. And thanks again to everyone who stuck it out with us. Jumping right into the questions. With vaccines appearing to be entering the marketplace, should employers consider requiring vaccination part of a return to work strategy?
We think that is going to be the trend. Yes, both from a civil standpoint, what public health officials will require for public transit, and what employers will require based upon trends that we've seen historically. For example, the university setting, it is required if you're an employee as well as student attending that you have vaccinations, certain vaccinations. So we believe that the employer will be empowered both from EEOC and other governing bodies to make vaccinations for COVID-19 a requirement for continued employment.
Okay, I'm kind of taking these in chronological order this time, and so we're jumping from the beginning of the presentation to the end of the presentation. So the next question is, did the 14-year-old girl who died of COVID have underlying comorbidities?
As far as what was reported, no, but they're continuing to, they're not providing any details on the clinical outcome or clinical relevance, but in the articles that I've reviewed, there were no pre-existing conditions pointed out.
Okay, and regarding the data you show every week on number of tests, this is a question related to that. Why do we measure the number of tests and expect that number to rise? Shouldn't it be a consequence of number of people who present symptoms or have risky contacts? If we do a lot of PCR testing with no strategy, don't we risk having a lot of false negative test results?
No, not necessarily. So we watch that number in terms of number of tests because we know that surveillance is key to articulating accurately the burden of illness. Put another way, if we don't test across the board as much as we can at this point, then we are going to continue to underrepresent the burden of illness, right? And that's a classic paradigm of pandemic and epidemic incidence and prevalence understanding, that only when we have a sufficient number of tests for the level of illness in the population will we accurately articulate the true burden of disease. And that's why we're seeing the seropositivity studies that have been published by CDC and others come into play, because we understand that we're likely underreporting because we don't have sufficient number of tests that are being conducted amongst those who are non-exposed and asymptomatic, and who may still have a positive result. So understanding, again, burden of illness is dependent on how much we are actually testing per our population.
Okay, here's an interesting comment about people trying to use up their FSA dollars before the end of the year, something I hadn't considered being having an impact. The question is also a comment. Having worked in the ICU for 10 plus years, we historically reach peak capacity at this time of year. Many patients are trying to get in before the end of the year to use their FSA dollars, and this is compounded this year due to many delaying treatment and procedures because of COVID at the beginning of March. When looking at metrics, It is important to include the percentage of beds in the hospital setting of patients diagnosed with COVID. Are you aware of what these percentages are?
Yes, don't have them this week. We did present that data, I believe, 2 weeks ago, where we looked at specifically capacity of ICU beds per state, the prevalence of ICU beds, the occupied ICU bed number, and then the number of COVID patients in the ICU. So we looked at all three of those metrics to get to that point exactly in terms of understanding COVID specific numbers for ICU utilization.
Okay, another comment and a question. It's about a study published in the Annals of Internal Medicine from Denmark that involved 6,000 participants, and the conclusion showed that there was a 0.3% increased risk of infection among non-mask wearers versus mask wearers, and the person wonders if public health authorities in the United States may modify recommendations based on findings in this study.
I'm not aware of any modified recommendations or intent to modify recommendations. And if I understand the question and comment from the study, it's to suggest that those who wear masks have a lower incidence of infection compared to those who don't wear masks, meaning there's a protective factor to wearing masks, right? And certainly that may be a correlation, but not necessarily a causal relationship, which would be necessary for public officials to make recommendation changes. Put another way, if the mask wearing correlation is not specifically geared towards protecting the individual wearing the mask, there may be other factors that do so, meaning I am a mask wearer, so I hang out with a bunch of people that also wear masks in my social circles, meaning we're all protected a little bit better than those who don't wear masks, who may be hanging out with people who don't also wear masks. So that could have the same correlation of those who wear masks are less likely to contract COVID-19, but is not related to the protective factor of the mask itself for the individual, rather the behavior or the cohort.
Okay, we have time for just a couple more quick questions, and those of you who've submitted questions toward the end will answer those in writing, so be sure to refer back to our website. That might not be posted till after the holiday weekend, but we'll get it up as quickly as we can. Regarding the PAR 7, assuming that 7 days is the more conservative option, is that correct?
That's assuming 5 is the most conservative option. So if you test on day 5, depending on which scenario you're referring to here, testing on day 5 post-exposure asymptomatic individual would allow us to capture 7 days compared to a full 14-day quarantine period.
Okay, this question, I'm not sure exactly how to interpret it. Will the close contact quarantine be shortened as well as the affected person?
I'm not certain how to interpret that either. However, let's take a look at that in the Q&A opportunity, and we can kind of decipher what, if you want to reiterate that, whoever asked that question, we're happy to kind of drill down and address it for you for sure.
Okay, that sounds like a good idea. Has the CDC commented on the antibody strategy?
At this point, no. The CDC has not commented on serologic testing being utilized in what we have proposed. However, as they have continued to do, we think they will in terms of recommending things that we recommend. Thereafter, we recommend them. Not any terms of a correlation of our recommendations having an impact on CDC. However, we believe we're able to read the tea leaves a little bit more quickly and communicate the strategy a little bit more quickly than obviously the tremendous amount of effort it takes to make recommendation changes at CDC.
And one last question, it's kind of an interesting one. Would a second dose of the vaccine required to be from the same manufacturer as the first dose?
Everything we're reading and understanding is the answer to that is yes, right? Because the vaccines all differ in terms of their makeup, even how they're produced, and their means of providing protection in terms of seroconversion, how your body responds and develops antibodies. So, for example, if you have Pfizer's vaccine, which is an mRNA-based vaccine, and introduces the mechanics of producing immunity, production in your cells, it's different than if you have a different vaccine that causes your body to manufacture antibodies in a different fashion, right? So we want to make sure that you do receive the same manufacturer's vaccination that you received the first time in your second dose.
Okay, and I wanted to tell one person who was asking about WorkCare's capability of delivering the vaccine. We've talked about that in a previous webinar, and we will be getting into that again in the coming weeks. That we do have a strategy that we're developing to deliver vaccines to essential workers. So at that, I guess we conclude for today. Wishing all of you a really happy Thanksgiving holiday. Be safe, wear your mask, practice social distancing, and we'll see you next week. Thanks,
Excellent.
Dr.
Thanks,
Harris.
everyone. Thank you, Karen. Thanks, everyone. Stay safe. God bless.